Good afternoon, everyone, whether you're listening live or recorded. Welcome to the BTOG Essential Update with a surgical bent for this multi-professional audience. Next slide, please. I can reassure you that the sponsorship of BTOG is entirely independent of the content, whoever is sponsoring the event. Next slide, please. And I welcome on behalf of BTOG two important people in the organization, Don McKinley and Gina Stevens, with their contact details here. Contact them if you have any problems this evening with IT issues, and certainly with BTOG related matters out with this meeting. Next slide, thanks. In terms of submitting questions, this is a live event. Please use the control panel asking questions on the chat function, and we will deal with this at the end. There will be a certificate of attendance, which will be contingent on feeding back some positive comments. And you can indeed access this archive for up to 4 weeks after the end of the presentation. Next slide, thanks. The agenda, we've got three eminent thoracic surgeons talking about their aspects. We thought it was quite important to keep up to date with advances in surgical practice and management. And the first of these is Professor Eric Lim from the Brompton and Harefield, talking about the Violet study, a really important landmark study that shows that surgeons can also do randomized controlled trials, and this shows the great amount of cooperation that can happen to allow this to recruit ahead of target. Eric, please proceed.
Thank you very much, Alan. Thank you for the kind invitation to BTOG to speak today. I'm talking about Violet, which is a randomized control trial of keyhole versus open surgery for lung cancer. Here are some of my disclosures. Many of you may have heard of Violet as a UK parallel multi-center superiority group design randomized control trial, where the surgeons in the UK compared keyhole versus open surgery for lung cancer. The study protocol has already been published in the BMJ Open, and you may wish to refer to it for more or greater details. But in summary, we recruited patients more than 16 years old with known or suspected lung cancer, clinical stage T1 to 3, N0 to 1 or M0, with disease considered suitable for both VATS and open lobectomy, and randomized them in a one-to-one fashion, stratified by center and minimized by surgeon. So each individual surgeon gets to do the same number of open and keyhole operations. The definition of VATS and open are conventionally defined according to CALGB criteria, and lymph node dissection was standardized in both groups according to IASLC stipulations. After the operation was done, dressings were placed across the wound so that patients and assessors could not decide or know if the operation was done keyhole or open by looking at the scars. And in fact, they were actually tested and asked if they knew or could guess which incision they had. And suffice to say that in the in-hospital setting, it was 50%, which means that it is no better than chance for patients to guess whether they're keyhole or open surgery. Violet is a tremendous study. We've randomized over 503 patients, and we randomized 4 months ahead of schedule, thanks to the thoracic surgical community in the UK. And I believe that people always ask me, what's the success of Violet? And the answer is because we were friends. The participating surgeons knew each other very well. We had a very good rapport, and therefore, when the time comes, the need to randomize, we could write each other a WhatsApp chat group and have informal encouragement to actually improve randomization. In total, we screened over 2,000 patients for entry, randomized 503, 256 to open surgery, 247 to VATS. And as you can imagine, from a trial this size, the baseline characteristics will very well match between the two groups. With regards to the keyhole operations, the majority were done using 3 ports, and that's 58%. And the second most common incision was 1 port at 20%. For thoracotomy, I thought that the UK standard was posterolateral, but that only happened in 80%, and anterior thoracotomy was conducted in 20%. For every surgical study, there needs to be some quality assurance, and the benign resection rate, despite known or suspected cancer, was very respectable at 1.2%, with an in-hospital mortality of 1.4%. Conversion from keyhole to open surgery was 5.7% when defined by allocation to VATS, and 6.4% when defined as attempted VATS lobectomy. The difference is if you were allocated to VATS and had a biopsy to confirm cancer, some of them were not cancer and therefore you closed, and hence a more discerning definition for attempted VATS lobectomy. On the whole, the number of conversions were very small, 14 out of the 246 randomized, and the two main reasons were adhesions and bleeding. The in-hospital results suggested that patients who randomized to VATS had a 1 point lower visual analog score in terms of pain by post-operative day 2. Now, pain is a difficult outcome to evaluate because it's not an independent outcome. It is influenced by the amount of analgesics you have. And when we accounted for each and every analgesic a patient received, we found that the VATS lobectomy patients had 1 point less pain despite receiving 10% less analgesics, confirming that a keyhole operation is in fact less painful. We prospectively defined all the key complications that we wanted to track, and to my surprise, we found that patients who were randomized to VATS had a 26% reduction in hospital complications. Now, there were two complications that were noted to be higher in the VATS arm, neither of which was statistically significant, but thought to mention for completeness. One of them was intraoperative bleeding at 4.7% for VATS and 0.8% for open, and one was persistent air leak, defined as the need to go home on Heimlich back, which is 15% for VATS and 8% for open. The serious adverse events were similar in both arms of the study. We found that the median length of stay was 1 day shorter with VATS and a median of 4 versus 5 for open surgery, and that was considered to be highly statistically significant. With regards to oncologic safety and efficacy, the number of lymph nodes harvested in both arms were the same, lymph node stations, which was 5, and the median number of mediastinal lymph node station harvested was the same at 3. Some consider upstaging of the lymph nodes from clinical N0 to 1 to pathologic N2 a more discriminating feature of the quality of lymph node dissection, and we're pleased to report it was 6.2 in VATS and 4.8% for open. Complete R0 section was the same in both arms, approximately 97%. Our primary outcome was physical function at 5 weeks, and we found a statistically significant improvement of approximately 4.6 points in terms of a physical function scale at 5 weeks. Physical function is a really difficult outcome to interpret. So if I just say that it's a score from 0 to 10, so 4.6 actually represents 4.6% difference between the two groups. And one might ask, well, that physical function is quite small, the difference. It's because physical function is a function of time. It's not the same at each time point. And whilst at 5 weeks, you get approximately 4.6% difference, at 2 weeks, the difference was closer to 13%. So the closer the time of surgery, obviously, the greater the difference in terms of physical function. Pain, no matter how you measured it, whether it's by prolonged incision pain or using the visual analog scale or pain scores on the EORTC QLQ-C30, was consistently lower and in favor of VATS. Procedural safety post-discharge, with regards to serious adverse events, it was found to be 30% in the VATS arm and 37% in the open surgery arm. The causes for readmissions and death, readmissions are given in the table on the left, and the cause and reasons for death were given in the table on the right. The principal causes for readmissions were infections and medical procedures, and the principal cause of death was disease progression. With regards to adjuvant treatment, prior to Violet, there was an impression that if you had keyhole surgery, there was a greater uptake to adjuvant chemo in a shorter span of time. We did not find that to be the case, but with Violet in a randomized control trial setting, underscoring the importance of the randomized control trial design, we found that the uptake of chemotherapy was the same and quite poor, in fact, in both arms. Of those who were eligible, around 50% actually accepted chemotherapy in the VATS and open arms itself. With regards to recurrence and new cancer, there were 18 recurrent and new cancers in the VATS arm and 21 in the open. The majority of which tended to be lung, which centered around a local regional recurrence as opposed to distant recurrence. With regards to oncologic quality in terms of survival, there was no difference in overall survival nor disease-free survival. Having said that, there were many non-randomized studies prior to Violet suggesting that keyhole surgery had a greater impact on overall survival, and I never thought that would be the case. Please note that the hazard ratios for survival is 0.67 and progression-free survival was 0.73, both in favor of VATS, but we were not powered to assess its outcome, and we will be pooling the actual 5 randomized trials to date to be able to better address this question, hopefully in the near future. For all the quality of life scores, it was either no different or in favor of VATS. There was no situation in which thoracotomy had a more favorable outcome, and that was quite surprising given that there were over 43 measures which were actually estimated for our patients. In total, due to hospital readmissions, complications, so on and so forth, we found that the cost of VATS were in fact much less than the cost of open surgery. This is usually quantified in an incremental cost effectiveness ratio, which is derived by dividing the total cost up to 1 year against each quality of life achieved. And normally it's associated with an expense to quantify for each improvement in quality of life. For Violet, it shows that patients who received VATS as an access saved the country 46,000 per quality associated life year, not costed the country, saved the country 46,000. And I think that's one of the most incredible findings that we have so far. So in conclusion, VATS lobectomy is associated with less pain, significantly lower total complications, shorter length of stay, and this was achieved without any compromise to procedural oncologic outcomes or serious adverse events. Superior recovery continued after discharge with improved physical function and vast majority of secondary quality of life measures up to 1 year. Less complications, less readmissions continued to be observed all the way up to 1 year without any difference in recurrence, disease-free, and overall survival, leading us to conclude that VATS lobectomy is more effective and less costly compared to thoracotomy. I alone did not do Violet. Violet was the child of the labor of many, many people from around the country, and as well as the many patients who very generously consented to give up, and to give up their personal choice to allow us to randomize them into Violet. And I really want to thank the sites, the investigators, and especially the patients. Violet was eventually published in the New England Journal Evidence and has achieved very high impact with a lot of favorable reviews, which leads me to thank everyone who took part in the trial, the BTOG organizers for inviting me today, and for your kind attention for my presentation. Thank you very much.
Eric, thank you very much for that very clear, concise, and very timely description of Violet. As I said at the beginning, we'll take panel discussions at the end. So I'm delighted to introduce the next speaker, Mr. Babu Naidu from now Queen Elizabeth Hospitals in Birmingham, ex-Heartlands, talking about a very topical thing in cancer in general, pre-op optimization and prehabilitation for lung cancer. Thank you, Babu.
Thanks, Alan, for the opportunity to present a subject which I'm really very passionate about, and that's prehabilitation. And we know prehabilitation forms part of the optimal lung cancer pathway, and that we need to try and implement it as early as possible. And what I'm going to do is to present a brief summary on the emerging evidence around it. And there's been a huge explosion in the number of publications, as you can see here. Then I'm going to tell you a bit about the difficulties actually delivering it currently, and then some of the new digital solutions that would potentially be helpful. But first, I show you this picture of a colleague and a friend, Paula Agostini, for 2 reasons. The first is that for the last decade, she's been publishing work on risk factors for complications, modifiable risk factors, namely COPD, exercise capacity, lung function, smoking status. And that's, of course, very relevant to our talk today. The second reason I show you this picture, which is taken about a month ago, which is the base camp of Everest, is really to bring to your attention that actually performing lung resection surgery is rather like climbing Everest. Now, when you climb Everest, you undergo a sort of rehabilitation program. So similarly, should we not be doing this for our patients? So when I talk to my registrars about whether they, address the issue of prehab with a patient that they've just consented for lung cancer surgery, they always say to me, well, yes, boss, I've done it. I've told the patient, go and walk more, eat healthy, and stop smoking. But of course, prehabilitation is a lot more than that. It's a multidisciplinary approach where you make an assessment of the patient, their baseline, their risk factors. You then personalize a program for them, and then you measure the impact of that as it goes along. And of course, it always has physical activity in it, but depending on your assessment, includes a number of other interventions. As mentioned, there's been an explosion in the number of publications around prehabilitation. And this is a good review published last year in Thorax, which looks at the 14 randomized controlled trials and really shows that overall and major post-op complications are severely impacted by prehabilitation. And if you look at the relative risk, it's on par with minimally invasive surgery. But not only that, there's an improvement in exercise capacity, there's an improvement in quality of life and lung function. The second thing is that in a subgroup analysis, they showed that the shorter, more intense programs had a more reliable effect on length of stay and complications, and longer programs had more of an impact on exercise capacity. The current version of our guidelines on enhanced recovery recommend prehabilitation in those patients only with borderline lung function. But perhaps in the next iteration, we might be thinking about applying prehab for all patients, but perhaps slightly longer in those who are borderline. What about delivery? Well, prior to COVID, we conducted a national survey of enhanced recovery, and some of the barriers that were there were around time to surgery, staffing, having a team that had consistency of information. And of course, following COVID, most badly affected by services that are affected were rehabilitation services. In our own department, where we were quite active in prehab, during this period, we've had very little. And when we conducted a survey of this last year, you can see that's a national picture. So are there any solutions to this? Well, digital prehabilitation is a potential, and we developed an app-based COPD pulmonary rehab program, and we delivered it in a group of patients, and we showed that it was feasible to do so, even in those patients who were elderly and technology naive. And we were able to deliver on average around 3 weeks, and this was associated with a 100-meter increase in their shuttle walk. The outcomes, the post-op outcomes, are comparable to a contemporaneous conventional pulmonary rehab group, and of course it was much cheaper. But who better to tell you about this than the patient? In the second iteration of the Fit for Surgery, our team, which consists of a younger looking surgeon, but also patients, dietitians, rehab physios, thoracic surgery physios, lifestyle behavior change experts, sports psychologists, health psychologists, and researchers. The team has now developed the app further into a hybrid app, which can be used on multiple devices. There's a lot more personalization. We're using a heart rate monitor to give biofeedback. We've embedded motivational theories such as goal setting into it. We've also included outcome measures. So patient-reported outcome measures of quality of life, a sit-to-stand test, and we've also incorporated the nutritional assessment and intervention. So using structured exercise, as an example, we make an assessment using a fit test, which is done within the app. The patients then can select the exercises based on their preferences. Some guidance is given based on their fit test. And then as they perform the exercise, they record their rate of perceived exertion or the BTOG scale. And based on that, the app then makes recommendations either to increase or decrease the amount of exercise they perform. And then they can see this in a weekly chart. I mentioned the nutritional triage, which we do within the app. So there's a patient-generated subjective global assessment tool, which triages patients into low risk, medium risk, and high risk. And in the low risk, they just get the information through the app. Through the medium, they receive high-calorie oral nutritional supplements. And high risk, they get to see a dietitian. And finally, there's a lot more personalization with the app. So here's one example. You can see that if a patient marks themselves as breathless, then information on how to manage breathlessness is displayed to them.
I said, yes, what is it? And he said, we're doing a project, rehabilitation exercises for people having lung surgery. Would you be interested in taking part? And I said, yes, I would.
I found the app extremely easy to use.
I had a very, very good explanation by the researchers who showed me what I needed to do, how to do it, and all the rest of it.
Switch it on and you've got all the exercises there by the side of you.
And my feel-good factor has shot up at a rate of knots that far better than last time. So the recovery rate has been much, much quicker and much, much better.
And you know how well you're doing, and it just spurs you on. It's extremely easy to use.
But certainly having that and getting as fit as I was able to helped me prepare certainly for the operation and get ready for that.
My recovery from that has been amazing. The pain has been absolutely nothing like the first lung operation.
But it was extremely easy. If I can do it, anybody can do it.
Each day you can see your oxygen and your heartbeat, and it tells you how you're doing against the last time, and it's really, 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 really good.
It came as a surprise how simple and straightforward it all was. I think that app helped me enormously for two reasons, both physically and also psychologically.
I thought it was good. It was demonstrating that old guys can still do exercises, which is good.
I think that's a very powerful message. And based on the feasibility study, the NIHR have funded us to do a large multi-center trial. And thanks to the success of Eric and co, we have now got funding to do this 900 patient study from 20 lung cancer surgery centers, recruiting 2 to 3 patients a month for a couple of years. So if you are interested in your center being part of this, please do drop us a line. But to summarize, rehabilitation is an essential part of the lung cancer pathway. It is for all patients and needs to be tailored. There are issues with delivery. Digital solutions are a potential problem, as a potential solution. Thank you very much.
Babu, excuse me, thank you very much for that. We have also started a prehab program, but we're still very keen to get involved in fit for surgery to randomize our patients. So Babu's talked about optimizing our patients before surgery. And now Matthew Thomas, one of my recently appointed colleagues a couple of years ago at the Golden Jubilee in the west of Scotland, having spent some time in the factory in Shanghai, he's going to talk about segmentectomy as a possible alternative for the management of primary lung cancer. Thank you.
Good evening, everyone. Thank you, Alan, for the introduction, and thank you, BTOG, for allowing me to talk to you all about segmentectomy for early stage lung cancers. As you heard, I'm Matthew Thomas. I'm a thoracic surgeon at the Jubilee, and I don't have any conflicts of interest. So I thought I'd begin with the basics, the definitions. So a bronchopulmonary segment, by definition, is an anatomical portion of the lung with its own segmental bronchus and vessels. And the vessels include pulmonary arteries, bronchial arteries, pulmonary veins, and lymphatics. Next to it is this picture of the nomenclature we use. And I think it's important that everyone gets used to this nomenclature, because as surgeons, we tend to mark the specimens now saying RB6 and send it to the pathologists. And they obviously are getting used to the nomenclature, and the same nomenclature is used in the MDTs as well. So I think it's worth everyone gets used to this, and you can look at it later on in the slides. For any surgery to be useful and be worthwhile, there should always be an anatomical and physiological basis for this. So if we look at this picture, it shows how tumors spread. Now, tumors spread, as we know, along the windpipe and along the blood vessels, which are the arteries, and the veins and the lymphatics. Now, whilst the arteries and the airway are in the center of a segment, from this picture you'll see that the veins and the lymphatics actually run in the intersegmental plane. And that's important to understand, because this is what a wedge resection looks like. In a wedge resection, you would cut away the tumor with the surrounding parenchyma. You will probably take away some of the airway and the arterial spread, but you won't take away the spread through the lymphatics or through the venous supply. And for that, a segmentectomy was designed. In a segmentectomy, we cut along the intersegmental planes. So let no one tell you that a segmentectomy is a glorified wedge. There's a big difference. So this is the main physiological basis and or physiological hypothesis for how a segmentectomy works. Now, let's take the simple example. I wish I could show you using a cursor, but here is a nodule in the lingular segment of the left upper lobe. You might be able to see some airways in the area. The airway you see directly in line with the nodule is the inferior lingular segmental bronchus, and the one above it, the superior. The airway above it is the anterior segmental bronchus. So post-lingulectomy, this is a picture on the right-hand side which shows what the post-operative area looks like. And you can see the stumps quite clearly, B4, B5 marking the bronchial stump, the arterial stumps marked as A4 and A5. And you can see from here that the parenchymal stapling has occurred along the intersegmental plane, as you can see the vein to the anterior segment clearly. These are some pictures of nodules which are well contained within a segment. So on the left, we have a nodule in the posterior segment of the upper lobe. And on the right, you have a nodule contained in the superior segment of the right lower lobe. And both of these can be resected by performing a single segmentectomy. And this is in contrast to the pictures that I'm showing you now. So in the previous ones, you would easily get 2 centimeter parenchymal margins, whereas if you look at the picture on the left, the nodule straddles 2 segments. It straddles the apical and the posterior segmental areas of the right upper lobe. And therefore, I went ahead and did a double segmentectomy. Similarly, on the right-hand side, that particular nodule in the left upper lobe straddles the apical and posterior segments. So you would have to design your segmentectomy based on ensuring that you've got enough parenchymal margins. And if you think the parenchymal margins are spilling over into another segment, consider a double segmentectomy. Now, those were relatively easy to do, but this one is complicated. This is a nodule that's in the right lower lobe, and it sits between the lateral and posterior segments of the right lower lobe. Any segmentectomy in the lower lobe of either lung is a little bit more challenging and technically difficult, but still achievable. So we've seen the physiological hypotheses of how segmentectomy can work. We've seen what we can achieve in terms of the resections. But as a surgeon, the next few questions which I would ask myself is, okay, I know why I can do it, but how should I do it? I mean, how much should I resect? Where did these 2 centimeter margins come from? Is there any evidence for it? So I'll present that to you. And then after that, what are the outcomes of segmentectomy? I mean, we are doing lobectomies. Is segmentectomy as good as a lobectomy? What are the outcomes? And then finally, we'll go through some unique scenarios. So the evidence we have is that we could be doing segmentectomy for nodules which are lesser than or equal to 2 centimeters. And we should ensure that they have, we should ensure that they're not invading the pleura, because if it does invade the pleura, tumor could spread through subpleural lymphatics. And finally, as I said earlier, you would want to design your segmentectomy such that you have 2 centimeter parenchymal margins. Now, to get to the intersegmental plane, you could do that in various ways. I'm sure the surgeons in the group would have various ideas, but these are the 2 that I have been trained and have used. So on the left, you've got parenchymal marking using indocyanine green, and you would basically divide the vascular supply to the segment concerned, inject indocyanine green, and the areas of the lung that are perfused will light up green, the others don't. And you can see in the picture the puckered area, and you can see the arrows showing that you've got enough parenchymal margins to resect that segment. On the right is something that I was previously trained on, and I still use it, is the inflation-deflation line and inflation-deflation technique. Here, you could either selectively intubate the segmental bronchus and blow it up, or you could divide the bronchus and then inflate the rest of the lung and then allow it to passively deflate. And obviously, air would have entered even the segment which did not have a bronchus through the pores of Kohn, but it would not deflate as quickly, and you're left with an inflated area which you could mark with your cautery and resect. So, so where did these? Here we've got Sutani's paper in 2019, which was put up in the Annals, and he looked at low and high risk chances of recurrence, and he found that if the nodules were lesser than or equal to 2 centimeters, and if parenchymal margins were adequate, then the recurrence rate was low. Of importance is the fact that if the nodules were on the pleura and had pleural invasion, then the chances of local recurrence were much higher at 28%. So that's an important point to consider. Now, the next question is what are the outcomes of segmentectomy? Thankfully, this year we had a large multi-centered trial called the JCOG 0802, which was a randomized control trial designed to investigate if segmentectomy was not inferior to a lobectomy. So what is this trial? Well, in this large trial, they had 1,106 patients, and they recruited everyone with a nodule which was lesser than or equal to 2 centimeters, and with every one of them having a CT ratio more than 0.5. A CT ratio basically stands for consolidation tumor ratio. And what's that in simple English? Well, if you look at a lesion, which is, say, for example, a mixed GGO, the consolidated part is basically the solid bit, and the tumor is the general abnormal area. So all of these had a solid component which was more than 50%. But this, we might grumble and say that our lesions are primarily solid. Well, 50% of the 1100 had a CT ratio of 1, which means at least 500 patients had solid lesions. So it might be applicable to us. It is applicable to us. They followed up the patients for 7.3 years as their median follow-up. Some of the follow-ups went up to 10 years. And during the surgery, they inspected the N1 nodes, and if the N1 nodes looked abnormal, they did a frozen section, and if it came back positive, they converted to a lobectomy. So the results from this trial were they had 550 odd patients in the lobectomy and segmentectomy arms, and the 5-year overall survival was superior in the segmentectomy arm. The 5-year relapse-free survival was about the same. The local recurrence was higher, twice as high in the segmentectomy arm. So even though they had higher local recurrence, they actually continued to survive, which meant that the deaths in the lobectomy group were due to other causes. Both lobectomy and segmentectomy had about 25% chances of having grade 2 or more complications when checked upon at 30 days. Now, from a segmentectomy perspective, you would have hoped that you preserve a lot of parenchyma and the final FEV1 would be much higher, but then this study shows that at 12 months, when they evaluated the FEV1, the segmentectomy group had a improvement or a gain in FEV1 of only about 3.5%, which was unexpectedly a bit low. Here are the survival curves. The red line is the segmentectomy line and the blue one is the lobectomy, and you can see that those curves go on all the way till 10 years, and consistently the segmentectomy has got a better survival. The relapse-free survival, as I indicated in the numbers before, are roughly the same. So what did they conclude? Well, they concluded that for all stage 1A non-small cell lung cancers who underwent a segmentectomy, those patients can expect a 5-year survival, which is of greater than or equal to 90%. And the other conclusion they came to was that based on this better survival, the recommendation, the JCOG group recommend that segmentectomy should be the standard surgical procedure for these very specific lesions. Now, if we have the same patient genetics and follow the same surgical aims, we would have exactly the same results. But in our country, do we have the exact same patients? Well, we have more fibrotic lungs, and they were excluded in this trial. Having worked in the East in Shanghai, I can tell you that their patients' fissures are much better. They occasionally have segmental fissures, whereas over here we tend, or wherever I've gone, the fissures seem to be more grade 3 and grade 4. So it makes it more technically difficult. Nevertheless, we persevere and do a segmentectomy. Now, with regards to N1, this is a complicated question, whether we should be converting to a lobectomy if we find that and whether we should be doing a frozen section, because Is it the same as systemic dissemination? I mean, for a lobectomy, if you had N1 disease, would it be just give adjuvant? The next question is about pleural invasion. We've seen that there is a higher recurrence rate if pleura is invaded. So should we go back and do a lobectomy? What do we do for recurrences? I can tell you in the trial, a quarter of the patients underwent further surgery, a quarter of them had radiotherapy, and about half of them had chemotherapy. So the question remains, what should we do? And the follow-up plan in the trial, well, they had CT scans every 6 months for the first 2 years. And following that, up to year 5, they scanned the patients once a year. They found that that most of the recurrences tended to occur at 2.5 years. Now, moving on to our current trends in the segmentectomy world, well, screening is becoming more frequent. It's then very in a lot of places in England, and we are diagnosing more and more smaller lesions. So I think we will have more patients who are eligible for a segmentectomy. Now, some of these patients would have nodules in structurally confusing bits of the lung, or might require complex segmentectomies. Few of us are able to three-dimensionally map out a CT in our brain, but most of us, or at least some of us, may not be able to, are not blessed with that ability. So there are lots of virtual planning softwares out there which might be able to help. So either we should use that or get trained in how better to read a CT scan. As a competitor, there are oncological trials for coming up soon, I think, for stage 1. But the message is quite clear. We have a 90%, more than 90% survival if we do a segmentectomy. In conclusion, segmentectomy seems superior to lobectomy for the right patient cohort. If we adhere to the oncological principles, then we should get good results. We've looked at those debatable issues in the previous slides. And in 2024, the CAL-GB trial will come out, which might attest the role of segmentectomy. Thank you. That ends my presentation, and thank you to BTOG.
Matthew, thank you very much for that real good talk through segmentectomy, which clearly with earlier stage diagnosis through screening or other means is going to form part of the future, particularly with the JCOG study. I have a couple of questions already on the chat. I would encourage those who are taking part in this live to pop in. So the first of these, Matthew, you've already alluded to. Do you routinely use frozen section on your N1 nodes? You talked about what to do when you do have N1 nodes. Do you routinely use frozen section?
So I wouldn't consider myself the UK expert on this. So this is my personal view, and no, I don't. I would just resect it, and when the patient comes to MDT, I would have an MDT discussion.
Okay, and since we both work in the same institution, I can speak on behalf of the pathologists that it's not that they're in any way work shy, but they are very anxious about doing frozen section blocks on relatively small volume disease. I prefer to look at them in paraffins. I don't know if anyone else out there has a different view.
Can I also add to that? So the Royal Brompton Hospital has had a legacy and tradition of doing routine intraoperative frozen sections with Peter Goldstraw, George Ladas, and they would do it routinely, and we have a card, and they would collate about 8, 9, 10 stations for the card to look for N1 disease. However, I've not inherited that practice because the presence of N1 disease for me, does not influence my choice of extent of resection. And certainly the influence for N1 disease on resection extent is a very unique to Japanese practice. And from my point of view, if you have N1 disease and refuse to do a lobectomy and do a segmentectomy, then from an oncologic basis, how does that apply when you have Hyler disease or interlobar positive? Would you then do a bilobectomy? And then if you go on even further, and therefore if you have N2 disease, would you do a pneumonectomy? So if the increasing transition or increasing the extent of resection doesn't hold, I personally question the value, unless of course you cannot achieve R0, but the actual value for a otherwise N1 positive that you can remove or is removed with the anatomic specimen for a segmentectomy.
Eric, I agree, and this is why I think my personal view is as soon as the nodes are invaded, it is systemic disease, and that's why chemotherapy in an adjuvant setting is important.
Thank you both. Babu, can I ask for some input from you personally and on behalf of your colleagues in Birmingham?
Yeah, I mean, we don't have a very strong history of performing segments. We usually reserve them for those patients who are borderline. We're having to reevaluate what we do based on this study. So it's a work in progress. But for us, obviously, it's the small tumors and those who are not fit for larger resections that we would usually reserve this for.
Okay, thank you. The other question.
Can I ask why, Babu?
Oh, that's a very good question. Because really, there may not be a huge difference between the two. In terms of preservation of lung function. I don't know whether it makes us feel better. Is that why we used to do it? But I do think that when our practice is changing, isn't it? We're seeing smaller and smaller tumors. Lung cancer screening is coming. So our work, and of course, we're seeing a lot more of this ground glass. And Eric, you're going to produce some guidance on us as to what to do with that as well. So I think, in that context, segments are going to be more important. And I think as a surgical body, we need to embrace that.
Thank you very much, all. Can I just go on to the next question, also directed towards Matthew, and sort of touching on what's already been said. So Matthew, and ultimately the other two, are you concerned that performing a segmentectomy leads to twice the rate of local regional recurrence for a mere 3% improvement in both survival and lung function?
Am I concerned? Well, these are statistics and numbers. Yeah, we've got to believe them. But my personal experience is I haven't seen many recurrences after performing a segmentectomy here.
And can I just say that the value of that question is I've had another one from the audience, comment from audience. We are worried about the twice incidence of recurrence in local regional things.
But then as we go on to look at their study, most of the deaths occurred due to some non-cancerous reasons. Certainly the patients were fitter after a segmentectomy, and they did get additional treatment if there were relapses.
So if I can paraphrase your answer on behalf of the questioner, no, you're not worried about that imbalance. Is that fair?
I think
you feel that overall survival and lung function is worth paying that in twice the rate of local regional recurrence.
So the study wasn't powered enough. I mean, they were expecting to look to get at least a 10% improvement in FEV1, and they have, I think, claimed in their study that it wasn't powered enough to prove that.
Okay, thank you. Can I be mischievous and ask you a question, Matthew? If it weren't for the advent of SABRE, and although everything we do is patient-focused, absolutely, for best patient outcome, would thoracic surgeons be doing segmentectomy or exploring it if it weren't for the advent of SABRE? Would we still be doing lobectomy?
We've been doing segmentectomies for a long time, or segmentectomies have been around since the late 1990s. It just became popular off late. The reasons to do a segmentectomy are both diagnostic and therapeutic. SABRE is, I mean, I wouldn't say always, but is often given without any diagnosis. By doing a segmentectomy, you get enough material to look for other genetic markers and you know, provide targeted treatment if required. Since we've started evaluating the outcomes of segmentectomy, it's proven that the survival is more than 90% at 5 years. I don't think SABRE has those kind of outcomes. So yes, I would do a segmentectomy.
Okay, and I'm looking to someone to rebut that argument out there in the audience. If you could use the chat function, if you don't mind. Eric, can I turn to you?
I would say that it's an interesting view on JCOG, because if you look at LCSG 832, the incidence of local recurrence was twice higher with segmentectomy. And if you calculate JCOG, actually it's 1.9, the risk of recurrence, and with a JCOG was 2.0. So in fact, the risk of recurrence didn't change between LCSG 832 and JCOG. Now with LCSG 832, based on a twice higher recurrence, lobectomy was declared as the extent of choice for resection. So what's changed with JCOG?
Okay. May I ask you, Eric, an equally mischievous question? It took approximately 25 years, correct me if I'm wrong, to do the VATS lobectomy versus open lobectomy. Where are we with VATS versus RATS lobectomy?
So that's a huge question. That's an important question. So I think this is a really important question to be serious. So VATS and open is a form of access. Robotics and VATS use the same access, which is thoracoscopic ports. And the benefits is what can be done inside the body with a 360 articulation with robotic arms versus what can be done using standard thoracoscopic instruments. So the value of the robotic surgery needs to be quantified. Without evidence of better clinical outcomes, you need to be able to wonder if it's okay to spend 2 million on a robot and an additional few thousand per operation. I've calculated based on Karen Redmond's study on micro lobectomy costing, because robotic surgery costs on average 2,000 more per patient. If we all did robotic surgery for all our lung cancer resections across the UK, then out of no reason, we would just cost the country 20 million more per year. And how is that justified? Why are we doing that? And is it okay? Is it right for all of us to just move into it? What's the rationale? I don't understand.
Okay. Matthew, can I ask you, as someone that is now working in quite a mature robotic thoracic centre, is there, compared with your VATS, your uniportal VAT segmentectomy, how does the robotic platform alter your surgical approach in segmentectomy? Forget lungs for a second.
Yeah, for segmentectomy, it's far easier to do a segment using a robot. I mean, you don't rely on an assistant to move the camera around. You can move the camera exactly where you want. You've got very precise dissection. You can actually do a lymphadenectomy of that N1 node, or you can do extremely good lymphadenectomy. I mean, I could do it with VATS as well, but I can control bleeding much better with a robot, and it's extremely precise. I use the ICG better, the parenchyma, the stapler seem better. Overall, I think the robot is far superior, or maybe I'm getting very used to it, to do a segmentectomy as compared to uniportal or even triportal VATS. It is my personal view.
Still looking for contentious questions from the audience, please. In the meantime, Babu, can I ask you that certainly in Scotland and the rest of the UK, we really are into prehab for cancer care, not just prehab for surgery. How does your program link in with chemotherapy, oncology, immunotherapy, multimodality therapy? Do you have separate programs, or do you have one big program?
That's an interesting question. So obviously we've had this study funded to look at lung cancer surgery. but increasingly we have a number of other specialties who are working with us to evolve that for their own pathways. And that includes radiotherapy, the SABRE teams, but also colorectal, hepatobiliary, and upper GI. And within these types of programs, there are some common contents, if you want, and then there are specific areas. So we're in the process of mapping out the pathways for these other areas and actually evolving programs that are applicable to them. It's a slow piece of work, but it's ongoing.
Thank you. Just received a question for Eric. Eric, do you consider it a failure if you have to perform an open lobectomy as opposed to a VATS? And if so, should this be a quality indicator for thoracic units?
Oh, great question. The short answer is no, because I don't think any conversion is a failure. And the reason why I say that is because we need to do what's right for the patient. And whilst we want to have a shorter length of stay, we want to have less complications, so on and so forth. We want to harness all the benefits of VATS, but that can never override safety. If you can't do the operation safely and you need to convert, please just convert. And also, I don't think it all overrides oncologic clearance and margin. So if you're struggling and you can't get an oncologic clearance or margin, please convert. And with regards to conversion rate, I think it's a reflection of two things. One is your case selection as to, do you just accept small, easy cases? Some very famous surgeons around the world who goes around the world maybe accepts patients which are very straightforward, and so conversion rates tends to be low. But surely there are some cases where single port vasculobectomy is not possible, a 10 centimeter tumor. It won't come out of the port. You just have to do thoracotomy right from the outset. There is no shame. I think the two principal aims for a surgical operation is do it safely and get complete clearance. And with regards to the access, that's secondary to the first two.
Oh, and I think all of us around the table would agree. But could I just ask that supplementary, should minimal access resection rates be a quality indicator for thoracic units?
I personally don't think so, because it's hard to match based on those two factors, whether there's predominant case selection and lower threshold for safety. I don't think just because you have a high VATS rate necessarily equates to a better outcome, but certainly every surgeon should be competent to do a vasculobectomy.
I mean, 10 years ago in UK, I think the VATS resection, vasculobectomy rate was probably quite low, around about the 20% to 30% mark, and only a certain number of centres did it. Correct me if I'm wrong, guys, but I think that vasculobectomy is offered in every thoracic centre in UK now. Is that correct?
As far as I'm aware, because vasculobectomy now is the majority access for all lung cancer resection in the UK.
Okay, and our certainly the details from Doug West that we get is usually 2 or 3 years out of kilter, but I think it's probably reportedly 60%, but probably realistically these days a bit higher. The time is now 18:28. Unless there are any other questions coming through or any comments from the panel, I will draw this to a close, thanking everyone for their attention and engagement, and thank to all the speakers for giving up their valuable time. Could I just end with one advert that these essential updates, the next BTOG webinar is, as you can see on the screen, ASCO 2022 in an hour, which is on the 16th of June, and also the first BTOG face-to-face in-person meeting is on the Friday, the 8th of July. And please refer to the BTOG website for further details. So, ladies, gentlemen, colleagues, friends, thank you very much, and have a great evening and a great weekend. Thank you very much.